So I'm just going to introduce you to Dr. Laxmi Balmuri first. So Dr. Balmuri is qualified from Osmania Medical College and completed postgraduate training in general medicine at Gandhi Medical College in India and did his SPR training at the Northwest Deanery. Dr. Balmuri has also worked as a consultant physician in endocrinology and bone metabolism at MRI since 2020 and leads the joint Thalassaemia endocrine clinic at Manchester Foundation Trust, which was started in August 2021. He's also published in peer-reviewed journals and is actively involved in undergraduate and postgraduate teaching, and he's currently an honorary senior lecturer at the University of Manchester. Dr. Balmuri.
Thanks, Eva. Thanks for a nice kind introduction. So, objectives for today's presentation would be a brief introduction to thalassemia's distribution and characteristics in England, and what causes endocrine dysfunction in thalassemia. I'm sure Dr. Nandini would have explained this morning talk about endocrine tissue injury in various red cell disorders. A bit of information about the growth and delayed growth, short stature, puberty, delayed puberty, how we can manage it, and hypogonadism, how we treat with HRT, and finally about vitamin D deficiency. It's a large topic, so I'll just try to move forward through a few of the slides. They are not clinically relevant at the time. So distribution of the thalassemia, you can see that. So thalassemia is common, as you can see in the slides, mainly about it's an Eastern Mediterranean region, Southeast Asia, that is in the green color graph, and also it's about Western Pacific area as well, and about something in the purple, it's mainly in the region of in Americas, it's not much, but the rest of the areas of where we have seen in the blue and green, that's very prevalent. Coming to UK, it's most common in Midlands and London, and also followed by most of the northwest of England and rest of the Midlands as well. So coming to quick slides about age group, we can see most of the people are young in age, and we can see people are getting older and older. And I think with the advance in the therapy with the thalassemia, expect more people in the younger age. So we may expect the shift to the right in the slide in the coming years. So this is about, again, distribution. Sorry for it's a very small and busy slide. Again, this is the data collection related to the people of origin of the thalassemia people in the UK. It's mostly Indian subcontinent, but also if you can see the almost middle of the slides, a lot of the data is not very clear. So it's more, it says other African, other mixed, other Asian people. So I think there's a need for improving equality in the collection of the data for us to know more about the distribution. And this is about a quick slide about what people are mainly on the treatment and how many are then transfusion and chelation, and some of them are on hydroxyurea. And the last slide is this is about the different diagnoses. It's all data collected from the UK recently. So again, this quick slide, probably may go fast in this. So, so what happens? Why in thalassemia the iron uptake and iron injury to the tissues are more common? So there will be an increased intestinal absorption, and also there's need of frequent transfusions that leads to more iron into the blood. Once the iron is, the transferrin saturation exceeds more than 70%. So then the free iron, that is a non-transferrin binding iron or labile plasma iron, will, that's a free iron, will be uptaken by the cells of various tissues, including, as you know, heart, liver, and also other endocrine tissues. And these reactive oxygen species cause tissue injury. That leads to organ damage. Okay. So what are the endocrine complications, what we are looking at? So we're looking about the pituitary. So pituitary is mainly, this is a no order, just coming from top to bottom to easy to remember. Even that's easy for me to remember as well, not to miss any organs. So in the pituitary, so we got mainly the 5 hormones. That's what we look in anterior pituitary. So, but we're looking at 4 because they're very common. So one is the thyroid function, like a pituitary TSH. Production will be impaired. It's like hypopituitarism. And then ACTH production also impaired. So that can cause cortisol deficiency, ACTH deficiency, and also to the gonadotrophins, GnRH deficiency, and also growth hormone deficiency as well. So this is related to the pituitary injury and causing endocrine deficiency, hypopituitarism in thalassemia. But we have other endocrine organs, example like a parathyroid. So we have 4 parathyroid glands they're situated behind thyroid gland in the neck, and pancreas, adrenal glands or suprarenal glands bilaterally, and gonads, both testes and ovaries. Can move on to the individual gland dysfunction. So hypothyroidism is one of the common manifestation of thyroid or complication. So how do we diagnose or what happens? So we got a couple of slides, I think, put next one next to each other. So if it's a primary hypothyroidism where, so I'm trying to talk to relevant to the thalassemia. So, but it's mostly the same for even other people, other endocrine dysfunctions, but thalassemia. If it is a primary hypothyroidism problem is with the thyroid, that means there is a reduced T4 and T3 secretion. And then subsequently, so what happens, the TSH will go up. So that is the primary hypothyroidism picture. With secondary hypothyroidism, that means the problem is with the pituitary. That means the TSH secretion will go down and thereby T3, T4 go down. Okay. So there's another one I put this slide is because we come across subclinical hypothyroidism. That is something that just preceding to a frank hypothyroidism. That is nothing but a normal T4, T3, but TSH is elevated. So because TSH is elevated, that is hypothyroidism. If TSH is suppressed, that is hyperthyroidism. So that is a quick slide to go through. And what causes? Again, the same, similar, anemia, thyroid deposition, hypopituitarism. Investigations, I put them there. So as we already discussed, we need PT3, PT4, and TSH. And if it is a pituitary, we're thinking it is a secondary picture. That means a T4, T3 low, and also a disproportionate low TSH. That means we can also check other pituitary hormones as well. So, and how we manage, we treat accordingly, the thyroxine replacement. So the slide that we are relevant to our patients we see in our joint clinics, it's mainly is that relevant to thalassemia. Or people with thalassemia on medications, particularly. Some of them are a lot of tablets they need to take. So it's important to ensure that they take levothyroxine, if possible, first thing in the morning, half an hour before, or take other tablets or food for the better absorption. So we've seen a lot of people, patients with just slightly adjusting the times of the tablets are only enough. We didn't have to increase the doses of thyroxine dose. So it's important that if you can't take thyroxine first thing in the morning for other reasons, things, at least I advise that can they take in the evening? I mean, but making sure that they're taken 1 hour apart or at the time of the sleep. So just for the better absorption, so a lot of people can improve their thyroid functions. So hypoparathyroidism, we mentioned 4 parathyroid glands. So it is again just because of the iron-free radical injury to the parathyroid glands. It's one of the very less common complication, but relatively common in the males compared to the females. Usually thyroid problems are usually common in females, even common with even like autoimmune or other conditions. Generally, thyroid problems are more common in female, but parathyroid here, hypoparathyroidism, is more in males. So what happens to the parathyroid? So I think I go to the next slide as well within it. So sorry, it's a very busy slide, but it's a very, very important slide. Only we pick up what we important for us today. So why parathyroid is very important? Because this is the one of the most important stimulus for the hypocalcemia. If somebody has hypocalcemia, parathyroid is the one first to act on. So this is parathyroid. In parathyroid cells, there is a calcium sensing receptor. So if hypocalcemia is there, so that drives parathyroid production in the parathyroid cell. So that in turn, the parathyroid, when it comes out, it works on 3 organs. So one is the bone, so increase the resorption from the bone, so it makes more calcium in the blood. And also parathyroid will stop excretion or increase the resorption of the calcium from the kidneys, and also increase the activation. It activates the vitamin D to active vitamin D. So in turn, active vitamin D will increase the absorption of calcium from the gut. So if parathyroid is very important for these all functions. If there is no parathyroid, we can expect all the problems with hypercalcemia because there is no absorption, and the calcium can easily excrete from the kidneys and not much absorption from the gut. So what we do next is, so that investigation is similar. So we check calcium, parathyroid, we check vitamin D. So what are the factors or chemicals involved in this metabolism? That's what we check, vitamin D, PTH, and so the diagnosis will come. So if it is a hypoparathyroidism, if we have low calcium, we expect high PTH, provided PTH is intact. Sorry, parathyroid glands are intact. If there is a parathyroid problem, you expect parathyroid hormones either low or low normal. So that's where we diagnose that. So in that case, so how do we manage that? I think so. We have to, the ideal management would be replacing parathyroid, but that's not possible because it's not available for in UK to give it for hypoparathyroidism, as it is kind of to be given in injections, expensive. So, and that's why we replace indirectly by giving the calcium, activated vitamin D. So, but it's not as good as replacing the parathyroid hormones. So what happens, why it's very important to manage, again, particularly the calcium levels. So what we aim at the calcium levels to be. So we try to keep the calcium levels low normal. For example, if the calcium range, normally different hospitals got different range. In our hospital is 2.3 to 2.6. So we try to aim between 2.1 to 2.3, something like that, 2.2, because more than that will ultimately excrete in the kidneys, because we know that there is no parathyroid and cause hypercalciuria and kidney stones. So we don't need too much of calcium to the people. So we don't need to aim for the hypoparathyroid. So we need to keep low normal range to ensure the health function in the kidneys. So if we suspect somebody with the calcium problem, the hypocalcemia, with hypercalciuria, we can check a spot urine calcium creatinine ratio. That's a quick method. That's only the 10 mils of urine. We don't need any preservative. But if we have positive, that means high calcium creatinine ratio, then it's a gold standard. We can check 24-hour urine calcium creatinine ratio, 24-hour calcium. That's a gold standard. So just to make sure that that's the true reading. Next, adrenal insufficiency. I think it's again, so it could be a primary where the problem is with adrenal glands. If the adrenal glands are involved first, that means it's a low cortisol. And when we check, people feel tired, unwell, and pale, and so all the pictures of hypocalcemia. And also, but if you check ACTH levels, they are high. So that's the primary. because the cortisol problem. If it is a secondary hypogonadism, the problem is in the pituitary. That means there is not enough ACTH is there to drive cortisol out of the adrenal cortex. That means you expect low cortisol and the low ACTH. So if they have a low ACTH, we check other anterior pituitary hormones as well. Causes would be the same. Investigations we check. So how do we do that in our practice here? So if somebody is feeling tight, actually we kind of doing a screening program now, like every year we do that. If every year, not exactly every year, at least 1 to 2 years with what we're trying to do that, is checking their morning cortisol. If the patients are coming in the clinic, random cortisol, we can only check. And if that is low, that doesn't mean that it is low, because the cortisol levels can go low by afternoon and evening. So what we do is we check morning cortisol whenever we can do that in the near future. If morning cortisol is low, that's probably more reliable. Then we try to get ACTH level at the same time. Or the best other thing would be we can do a short synaptin test. So that is probably most of the hospitals will do that. So we take cortisol and give ACTH injection and check cortisol again after 30 minutes. So if there is a adrenal insufficiency, the raise of the cortisol after the synaptin injection won't be as much. So there will be a negative. So there is test will be reported as a positive or negative. That means a negative test indicates there is adrenal insufficiency. So we need to replace the cortisol with hydrocortisol or any other glucocorticoids. So need to refer to endocrine. So if it is low, we need to treat it. So this is just a summary of the hypothalamic pituitary axis. So we check morning cortisol and if it's low, I think this is something that what age you need to ideally, it's like I think taken from the previous UKTS guidelines, and there will be a new ones coming up in the near future, UKTS guidelines wise, but I think this is what recommended from year 12 onwards to check it. And if it is relevant, check it regularly. And also we need to check prolactin, IGF-1, LH, FSH, estrogen. So these are all the rest of the pituitary hormones we can check and treat accordingly. Next one is the diabetes. So this is again due to pancreatic injury or family predisposition, because particularly the epidemiology shows that's common in the Middle East, Middle East Asia, and the cohort is like already they are predisposed to the diabetes. And other thing is the liver iron overload. Why people with the liver iron, people with the high liver iron can have diabetes, as well, because we know that gluconeogenesis and the problem with the diabetes, that is also very common there. So how do we do that? So oral glucose tolerance test is a gold standard. So so what we do, this is the WHO standard oral glucose tolerance test. So if test is abnormal, so how do we do that? We take glucose first thing in the morning, and then give it's fasting glucose, and then we give 75 grams of glucose load, and then we repeat the glucose after 2 hours. If fasting glucose is more than 7.8, or if 2 hour glucose more than 11.1, as per the WHO criteria, they are diabetic. And there is a intermediate forms like impaired glucose tolerance, that when it is the glucose is between 7.8 to 11.1, or impaired fasting glucose if it is more than 6.1 to 7. So why? So just a couple of more slides. Yeah, the hemoglobin A1C. So the other ways how we can manage can investigate the hyperglycemia. So definitely hemoglobin A1C, I think most of them are here. The hematologists, you know more than me about why we shouldn't be doing the hemoglobin A1C in this particular situation. Particularly the hemoglobin A1C is this is a way of measurement where the glycated hemoglobin measured in the preceded 3 months. So if red cell survival is not good, or if there is a frequent blood transfusion, so hemoglobin A1C is not that good. So the surrogate markers like a fructosamine and other glycated products like albumin, glycated albumin, or glycated proteins together, the fructosamine probably a better reading, but the frequency the measurement is valid for a month, but we don't monitor them every month because it's very difficult. But every 3 to 6 months, depending on the degree of the glycemic control to that patient, we will advise when to do it next time. So other way of monitoring is simply monitoring the glucose readings with the standard glucometers. They can check it over the period after 2 weeks, a few times, like fasting ones, postprandial ones. So that's another way. Or if they're coming, if you get able to get a random glucose, if they're symptomatic, if glucose more than 11.1 and symptomatic, that's also diabetes diagnosis. So the few ways we can check that. Recently, with the more technology is in, so we can offer them people with already a phobic to take the test and all those things are very. So we can offer them either a continuous glucose monitoring for a brief period or flash glucose monitoring like Libre or continuous glucose monitoring like Dexcom. So we can do that for a week or two. That will give us an idea what is the estimated hemoglobin A1C. That's another way, particularly with the complex situations where patients are unwell or pregnant ladies, we're not sure about the diabetes and situations. That can be very good. So there is some C-peptide and venous glucose ones. So this is a quick line about it. So pancreatic injury causing the diabetes. That means we can measure C-peptide levels that indicate what's the level of the reserve there, the insulin reserve in the body. So, but we have to check glucose along with that, because if it's a low glucose there, if somebody is hypoglycemic or not eaten in the morning, the stimulation to the C-peptide is not there. So that means you would expect a low C-peptide. That's why it has to be done with the glucose along with C-peptide. That will give us somebody idea about how much reserve they have got. If somebody is diabetic and hyperglycemic, it will give us an idea whether patients need insulin. Somebody has a low C-peptide, that means they would ultimately become insulinogenic and they may need insulin in the near future. So this is all we already discussed. But again, I think it's the recommendation is that to check our glucose tolerance test yearly since puberty. And then if there's a family history of diabetes, we started a bit earlier than that. Growth. So it's a quick slide. Again, it's a very busy slide, but it's very important me to understand. So we can see the first, the fetal. It's very fascinating to know that about 1/3 of adult height is already happened in the uterus. So that's very, very important. So uterine health is very important. And the infants contribute to 15% of the adult height, childhood 40%. And during the pubertal spurt, and it's about 15%. So a lot of things that we can do to help these grow, as expected. So the other thing. So I think probably we may go further down in the slides. We can look at individual things. So this is something like, you don't have to remember these phases, but I think so what it is that a lot of factors can affect the growth up to the age of 17. This is where, people grow up to 17 and after that stop growing. Some of them will grow a bit later, but it's because the epiphysis fuses after that. So that means long bones fuse and no growth can happen after that. So things like emotional factors, nutritional factors, epiphysis, anemia, a lot of things can influence throughout the childhood. And then from 6 years onward, 5 to 6 years onwards, so it's like hormones coming. If somebody has got a hormonal dysfunction, like a growth hormone, for example, liver injury, because we need like a growth hormone to produce IGF-1, we need liver. So if something happens to the liver, there won't be any growth. So again, it's important that whatever we give the chelation-wise, to just look at making sure that's not affecting other bones and iron overload. And ultimately the puberty. So there is an issue of interest, like again, so mainly the hormones, sex hormones dysfunction. And again, these are all like emotional and nutritional factors that all can affect the pubertal growth as well. The puberty. So why this is important, because we're going to discuss a bit about HRT and in the next few slides. What is time?
Yeah, thank you.
So so looking towards somebody, a female journey in relate to their hormone status. So if we look at that, so from 0 to 9, so in uterus, we know that. So what we are looking at the red line first, estrogen. So a lot of estrogen is there in the womb. Then there will be some estrogen up to 3 years. So after that, you can see that it's quiescent. It is not much of estrogen or anything like until the puberty starts. So probably we see in the previous slide, but the growth spurt happen and puberty happen, but early in the girls, then the boys. So that's why it's 10 to 14 years. So when the estrogen starts raising from there, so where the puberty, that means we start getting the estrogen rise to contribute to the puberty. Then after that, so to maintain sexual health, a lot of other metabolic health, bone health, so we need a lot of estrogen. But once it's the menopause, so in the UK, it's about 50-51. So when the ovarian function ceases, then estrogen will go down. And then we can see LH, FSH will go up at the same time. So this is the way, this is what normally we expect in the female. So if anything happens to this, so that will cause a lot of problems to the either puberty or to their general physical health, including the bone health as well. The boys, the male journey is again, so you can see that what we're looking at is the red line here is testosterone. So we expect high testosterone in the utero, a bit of testosterone before 3 years, but after that it's completely not, kind of very, very baseline testosterone. At puberty, it kickstarts. So the testosterone production kickstarts puberty and then growth as well. So when at the end of the growth, that high testosterone causes epiphyseal fusion, that means bones fuse and won't grow. That means growth is very fast during that. So the testosterone levels will remain very peak after, for a long time. Unlike females where you expect a certain steep decrease in the estrogen, it's not like that. Testosterone levels, the andropause, we call it as similar to the menopause in males. It's andropause. It happens very slowly. There's nothing like so. And again, it's not that severe compared to the females. That means a more need of estrogen kind of replacement or the use of the interventions are very useful in females. And of course, it's important into the male, but there is still the native testosterone levels are there for some protection in the males. And again, the LHFSH will go up after the slightly going up. In compared to the females, it will suddenly steeply go up with after menopause, but in males, it slowly go up. There is a line in females, it's a blue line, so not that, sorry, AMH, that's a green. The green line is important to know the ovarian follicle reserve. That means somebody how fertile they would be. So obviously you can see that the follicles numbers will go as follicles number grow up, the AMH also will go up. So it's the peak about 20 or so. So that green line is peak around that. That means we got a maximum number of follicles at that time. That means more fertile. After that, the follicles numbers will go down, as does the fertility as well. So it's important that sometimes we don't check AMH in everybody, but it's somebody who is it's important to reassure some of the patients of our patients to see if they got any chance of the a success of the fertility. and in which case we are kind of able to decide whom to refer to or when to refer to fertility clinics. I think we discussed some of the fertility. Okay, this is it's mainly for that. So we discussed most of the things that what are the hormones are important and age. So one of the factor to know how to monitor how they are progressing from the puberty point of view. So this is can done by the this is just standard staging. So this is very helpful if somebody to diagnose the delayed puberty and also how to monitor once we are healthy puberty induction. So how they are progressing from their puberty, whether they completed their puberty or not. So this is very important for us to frequently monitor when necessary. If somebody is definitely, there is a delay in the puberty and monitoring therapy. Okay, so some of the definitions probably we made. So delayed puberty is if it's a boy, it's more than 14, and a girl is up to 13 years of age, or they have very developed breasts. And these are the definitions from the Royal College of RCOG guidelines. So why it's important for us to know? So we need to know what are the standards that we expect for that particular boy or girl, whether they reach. So if they are passing this age and still they are not developed as per the Tanner stage, they are not the prepubertal or the puberty is arrested. So we need to know, and then if it is they're not reached, so we can give some treatment to stimulate the puberty for both girls and boys. So usually, so we have pubertal regimes, which I discuss in the next slides, but we don't give pills for the puberty induction. So we need to give estrogen. So as such, for a couple of years, because we need to prime the uterus for a couple of years, and then we need to give progesterone. So as such, when it comes to the pill, can't make somebody puberty progress. And also, again, the high synthetic estrogen in that, it's not very, it's good. It has got some metabolic consequences. That's why we need to give estrogen in different formulas that we're going to. So progesterone, when do we give progesterone? Progesterone we give after a couple of years of exposure to the estrogen, then we have to give progesterone because the estrogen causes uterine myometrial growth, that means hypertrophy, and we have to give progesterone to get them get periods, that means shedding. So to keep healthy uterus, we expect at least 3 to 4 periods every year. So at least that is the minimum. And ideally, it is a monthly period. So because we give estrogen continuously, or progesterone only intermittently as per the patient wishes, we discuss the patient how frequently they want to get the period. But what we're talking about is the induction wise, we give estrogen continuously. We only give estrogen for 2 years. We don't give progesterone. So progesterone we only give once they achieve the puberty. So this is again, we need to check the test wise. So because it's we need to start looking at it early from age 10 onwards to make sure that, because this is the time we can pick up if somebody is progressing, that's the way. Then if they're not, then that would be the good time, because we see a lot of people not completely achieve the puberty in adult stage, isn't it? So I think it's good to that pick up early and then take it from there. So physical examination is very important along with the biochemical. So it's I think I can go quickly. So it is in the male. So compare in males or boys, how do we stimulate or induce the puberty? So it's testosterone. So there are 4 different testosterone preparations. Usually either like the top one, because it's Satchanan, for example, we give frequently. We just follow the standard the guidelines from the, so this is a pediatric European endocrine the guidelines. So, and then we follow, and there is another one, testosterone. If you look at the 4 week for this 1,000 milligrams every 10 to 14 weeks, but that we use it mainly for the maintenance. Most commonly, I think usually we give starting with the short-acting injections, and then once in maintenance-wise, we usually go with the 3 monthly injections. And just details for the induction, it's not much. You can still use it, but it's not a user-friendly one. When we give a testosterone, it's important things that it's making sure that the hematocrit is not going up too fast, and also checking that it can cause dyslipidemia, and also we can check prostate, PSA. So we just to monitor at least every 6 months to 1 year, depending on how much they get testosterone replacement wise. Some of them not much in practice. So this is mainly the induction. So we're not talking about the fertility here. So that's why I'm not talking, not much relevant here. Girls. So we have, as I said, first we give slowly every 6 months. We gradually increase the dose of estrogen. Here's a patch. So we gradually increase the dose of the patch. There's tablets, 17 beta estradiol. Again, we gradually increase the dose. And again, it's different estradiol tablets. Once after they reach the 2 years, usually I tend to do a ultrasound scan just to making sure that, to look at the uterine development and healthy or not. And so then we talk about either then continuing HRT in adults as adults dose, or we change it to oral contraception, because that will help them to get periods and also to protect as a contraception as well. Help. And HRT, that will again, we can help them to get appropriate estrogen they need to have. And also we add progesterone in that time as HRT progesterone, so they can get periods as well. The next one is the hypogonadism. So we moved on further down. So people with the thalassaemia or other endocrinopathies, they can have hypogonadism probably likely earlier than in the other people, when before menopause. So because of either in the problem with the hypothalamus, pituitary, or gonadal failure. So again, the assessment would be the same. We check the estrogen levels, LH-FSH levels, and also there's the males, we check the testosterone, LH-FSH as well. So how do we treat? HRT. So if mainly basic thing is that if somebody, when we start HRT with a replace treatment, that means if somebody don't have estrogen, we replace the estrogen. But if they have uterus, that means we also need to give progesterone. So we can't give only estrogen, because the estrogen will build up the progesterone, the endometrial tissue. So definitely, if somebody has uterus, we need to give both estrogen and progesterone. If they don't have uterus, we can only give estrogen. That's the first thing. So how will we give that? So estrogen, we can have we have tablets, patches, and again. So if there is the combinations of the estrogen and progesterone, how we can give that if somebody needed both. So if they are premenopausal or perimenopausal, we can give as a like sequential. That means we give HRT, make sure that they get periods. If they are postmenopausal, we can give estrogen progesterone in a way that they don't get periods. That means we give estrogen continuously along with the progesterone also continuously, so that they don't get periods. but they get protection from the both estrogen protecting bone, and also progesterone protects the uterus. Okay. So the transdermal patches, transdermal, they have gel, patch, or spray, and the sequential, what's the difference between sequential and continuous is in the sequential, basically we discuss the patient that they choose to have periods, and continuous combined, they don't get periods. So the most commonly used safe preparation is the patches or transdermal, not patches, transdermal. So because it avoids the first pass metabolism from the liver, and also the metabolites won't be there in the oral, a lot of metabolite that can increase the metabolic risk, increase the VT, venous thromboembolism risk as well, and also the blood pressure, migraine. So I think the most user-friendly one is the patches, or people can use the tablets as well. If it is a so when we give HRT, if we're giving estrogen, we need to use the dose as appropriate. So we start with a very low dose, and then we gradually increase the dose as required. If somebody is young, premenopausal or premature menopause, they're very healthy, so we need to give more doses. If somebody is postmenopausal, they may not need that much, but they need adequate. Otherwise, the estrogen deficiency symptoms, you can see them. So gradually increase the dose. So when you add progesterone, for the people who need progesterone, so they can have a lot of side effects. So you may have to change the progesterone form. So either so they may not agree with one progesterone, so you may need to change it to different progesterones. So the side effects, as depending on the side effects, you may have to review the dose of the progesterone as well. Some of them from the Royal College, so for the tips wise, so it's mainly the benefits and the risks of different kinds of prescriptions that we discussed, some of them. And again, types of HRT we discussed. So estradiol, different equivalent doses for what it is. So we can, again, the patches. So usually we have like a 25 to 50 micrograms of estrogen patch. It's equal to 1 to 2 milligrams of tablets. And so this is what we usually start with. So we start with usually 25 or 50, and most of the healthy ones will be 75 to 100 as well. That's the estrogen patch. The tablets, we start with a small 1 milligrams, we go up to 2 milligrams, and the progesterone doses vary. I think we just lost topic. There you go. I know it's a very big topic, that's why I had just rushing. Sorry if I make you feel rushed, but you can always ask questions at the end. Okay, so what are the mechanisms of bone disease in thalassemia? Obviously, bone marrow expansion. It is again hormonal deficiency, hypopituitarism, either from the pituitary involvement or the endocrine organ deficiency itself, or kidney failure as well can lead to bone disease. And some of the, I think the chelation medication related to bone disease, I'm sure you're well aware of it, and you know when to look at it and to change it to different forms. So what happens if somebody bones are not strong? That means they got low bone density, that is osteopenia or osteoporosis. So they can have fractures easily, or they can have deformities. That's the thing. So how do you find, how do you make out whether somebody has got a low bone density or not? So we do a lot of tests nowadays, and the routinely scans, they say that probably bones are osteopenic, but also in the X-rays, the same thing that they usually tell. But we would expect if somebody has got hormone deficiencies or a significant thalassemia disease with the bone marrow involvement, and if they got fractures, so we expect them to have low bone density. Okay, so and how we measure and what is the significance of it? Okay, so DEXA scan. This is the basic thing that we when we suspect somebody to have bone density, we do that. So how do we interpret in thalassemia? Try to make it as simple as possible. So there are two numbers. We know two one is a T score and Z score. Most of the people with thalassemia are very young, and we see them in the clinics are less than 50. But so the T score we use it for people, the male more than 50, and postmenopausal women. So if it is young, the women are young, premenopausal, and men less than 50. So we use Z score. So Z score and T scores are almost similar up to the age, and after they become older, so we use T score because there is a difference between Z and T scores. So for younger cohorts, we use Z score, and older cohort, we use T scores. Okay, so so if it is the terms that we use that, so osteoporosis. Osteoporosis we use in generally for the older cohort, and in younger people we use the low bone density because there is no such term for that. But if they have a fracture with it, younger people, and then we can say the osteoporotic fracture. But otherwise, because the low bone mineral density. But it's same, they've got low bone density. Okay, so but Z score, when you use the Z score, the numbers are slightly different because the osteoporosis starts with if it is less than -2 itself, where the T score is a -2.5, but Z score it's so if anything less than -2 of the bone density in Z score, that is osteoporosis. If it is a T score, it's less than -2.5. Okay, so we also check vertebral fracture assessment. So that means when you request a DEXA scan, we also look at the same time they can do X-ray. That means bone density of the spine. So that can mainly to look at whether they've got any vertebral fractures as well. So it's a very important tool for somebody with low bone density, very severe iron overload and had a fractures, vertebral fractures. This is very important. So then sometimes this is important to help to monitor the fractures if they are getting any worse over the time. So I tend to do them in people who are complaining of the back pain, and we don't know whether they had any fractures at the same time. So it can be done at the same time. So you don't need a separate X-ray for that. So PQCT, that is a CT scan. That's a qualitative CT scan. So that is peripheral. So that means that is a scan. We have in our, I think only a few centers have it. That is to check the bone density in the peripheries. That is, I'm looking for mainly the quality of the bone, particularly in the cortices. So in people where we expect metabolic bone diseases like thalassemia and other things, we also expect a quality has gone down apart from the quantity that is the DEXA scan. So DEXA scan may not be accurate in a few people, may not give accurate results. And so if you want to know the quality of the bone, and then we can ask for the PQCT scan as well. So that will give us an idea if they got, sometimes. So the T score and Z score numbers may not reflect if somebody have a fracture or not. So if somebody with a good T scores may have early fracture, it means because quality of bone already gone, may not be shown in the DEXA scan. But if somebody has a worse score, T scores may not have a fracture because they still got a lot of mineralization there. So it's all depending on, that's why in conditions where we're treating the osteoporosis or low bone density, we don't treat the numbers. We look at the fracture risk actually. So fracture risk is the FRAX score. So we can calculate that. And if somebody has FRAX score is high FRAX score, even though normal or relatively normal the T scores and Z scores, still may need to treat them. So I think the age is another important factor that gives a fracture FRAX score will go if somebody is, because younger population, even they have a very horribly looking numbers, the still fracture score is very low, sometimes appears. That's why its quality of the scan is important to look at. How do we treat? Okay. So treat underlying cause, that's what we say that. So if they are premenopausal, and what is exactly to looking at? So bones can be, because it can be nutritional, or we check the biochemistry here. I think it's available. Most of the hospitals have got the biochemistry. You can check them apart from the bone turnover markers. So when people come to us, we also look at other causes as well to the osteoporosis, other than just only, we don't put everything to the thalassemia or any haemoglobinopathies. So we still look at celiac disease, myeloma screen, and looking at the hormones, vitamin D levels, kidney functions. So we treat underlying cause. If there are any reversible causes, we treat them. But if there is something like this, that means a good iron chelation at the same time. That's very important. So better the iron chelation, better the preventing the bone marrow expansion and the effect on the bones. So that is the fundamental principle. So if it comes to us with the very low bone density, we just don't jump on to treat with the bisphosphonates, because we just investigate them first, making sure that the chelation is very good or if they're doing fine. And then, because once young people, we bisphosphonate effect, because if you start them, you may need for a long time or many times in the future. So we have to be kind of, toxicity of long-term use also very great. So that's why we use it when it really needed. But if we have any other reversible causes, we treat them first. So making sure that, see whether the bone density improved or not with that. So when we come to us, so we make sure that the thalassemia is controlled well. And also if you vitamin D deficiency, for example, we treat it. And if see, so any other things and just we'll monitor the bone density in a year or two. If it's stable, it's fine. We don't need to do anything. If it's still low, that means then we will look into whether we decide whether they need a treatment and trial for and treatment for the 2 or 3 times, few years, and then see how much improvement it is made after that. So we have some time. So that means usually we will get a repeat DEXA scan in 2 years' time, unless people are very severely osteoporotic or low bone density, and the fractures are happening, monthly or something like that. Otherwise, we do it every 2 years or so. So what are the treatments we have? So we need to replace the calcium, which is low calcium, and the vitamin D. So there is one more log slide in the vitamin D. So bisphosphonates, so we treat them. Either we got oral, intravenous, different bisphosphonates. So hormone replacement therapy, this is important for the premenopausal women or postmenopausal women as well. It's very, we have a lot of people on HRT. So this teriparatide and the romosumab. So the teriparatide is a analogs. That means they increase the formation, is to improve the formation of the bone, whereas the bisphosphonates reduce the resorption of the bone. So the way it works is slightly different. So teriparatide, we don't have anybody, I think, in our hospital on the teriparatide, because the criteria for the teriparatide is very strict. We have to try bisphosphonates first, and the bone density levels are different for different ages. So we're talking about -3, -4, or something like that. Because thalassemia cohort have got very young people, even younger the age they are, you need to have a very low bone densities to give it. So it's not very easy, And I think we can manage with a lot of other things as well for them, but there is available. And the romosumab, which is recently approved, and we are even, I think we're still struggling to get some of the funding from the pharmacy, but it is there. So this is somebody whom you think these are limited duration, romosumab, so we can give, this is for 2 years, this is for 1 year. So because the funding is only there for that time, improve the bone, new bone formation. But after that, you need to have a backup plan. You can't stop it because the bone density will rapidly go down when we That means you again probably need bisphosphonates after that. And HRT, if they need, they have to be able to combine with that. HRT is very important more for a lot of people here. Looking if anything else. So these are the things that what we look at, the calcium and bone things. So we check vitamin D, parathyroid. I think the recommended is up to 12 years, 30. So we check them calcium creatinine ratio, least first time. And if there are already sort of problems with hypocalcemia, definitely with the hypoparathyroidism patients, we check them. And also for already low bone mineral density and HRT. So this is the last slide. So what is vitamin D deficiency? So if we, it's mainly, I think in general, UK has got similar. This is taken from the NICE guideline. So to keep it simple, if the vitamin D deficiency is less than 25 nanomoles per liter, insufficiency is 25 to 50. More than 50 is the normal vitamin D levels. So how do we treat them? So we need to treat them with probably so you can treat with the cholecalciferol or calciferol. That's the vitamin D2 replacement. That's what we do for a lot of our patients. There's another one we just heard the previous slides is the activated vitamin D. That is the alpha calcidol or calcitriol. That is for people with the renal failure because there's activation is not there, or with the hypoparathyroidism. So you may have to give different. So you may have to give both activated vitamin D and vitamin D itself. So for people who has a vitamin D deficiency, a lot of people in the UK have got a vitamin D deficiency. So how we treat, the principles are to find out what do they have there, what is the diagnosis. Either they have a deficiency, insufficiency, or normal levels. So if they are deficient, that means we have to give them loading dose. That's a fundamental. So you have to give loading dose. That means overall dose is about 300,000 units. You have to give over a period of few weeks to few months time. Either you can give, there is no right or wrong. These are some examples given in the NICE. So I'll just put that there. So you can give either 20 to 40,000 units every, first few days. We give standard, like for us, 1 week to 10 days, we give 20,000 units every day, followed by every week for a few months, like 3 to 4 months, and then followed by daily maintenance therapy, things like that. So this is the loading dose, okay? And we given only for people who are deficient. Either if they are insufficient, that means 25 to 50, either, so you may start giving a maintenance treatment, or people may need a loading dose as well, but as not as much intense. But it is, we can give loading dose, but maintenance dose is very, very important. People who are already sufficient, you don't need a loading dose. That means we don't have to give these 20,000 units or 40,000 units capsules. So what they need is 800 international units every day. So we don't have to treat them with the tablets every time. If people can make their own vitamin D, sun exposure and things, it's difficult in the UK here, but it is something we can manage, either somebody, we think that keep going into vitamin D deficiency and insufficiency repeatedly. I think better to put them in a maintenance dose. We keep it as a 20,000 units per month or every 2 weeks, just continuously, so that they don't go into vitamin D deficiency. Because we've seen otherwise, repeat times people will come with the vitamin D deficiency anyhow. So once they're sufficient, then we will ask the GP to continue with the 800 units. People can buy them now with 1,000 units. They can easily 1,000 to 2,000 units daily, so they will take it. It's easy to buy, but it's very, very important. So maintenance dose is 400 to 800 unit. It's different in different countries depending on how much sun exposure it is. In UK, it is about 800 internal units that totally recommend. So please, very much.
Questions from the room? Any market checks?
Really, that was incredibly thorough and I learned a lot. I've got two quick questions.
Okay.
One is the bisphosphonates. Is there an age below which you wouldn't give it? Because I've got some quite young patients in their 30s and in Oxford they won't give the bisphosphonates because they're very young. My second question is, can you give too much of it? Is there a
Oh, yeah. Okay, that's a very good question. So I know here in MRI, the young people are managed with a pediatric endocrinologist, but you could see that we have seen the patients, the kids were given bisphosphonates when they are young, but the safety has, there's a more of a concern about how much we give. So I don't think, as far as I know, my expertise may be wrong, but there's no limit to where to give it. I think it's important that when they give it, making sure that any other factors they can to basically treatable causes, and when they give it, they have to monitor it. And I think the pediatric regimens were different. They used to kind of, still they are in place. Parts of the world, like they give everything.
Yeah, about people in their 30s.
30s, I think no. So sorry, yeah, there is nothing like that. But as I said, so we make sure that nothing else is there. But when we start, we just make sure that we give 2 or 3 years rather than a postmenopausal like we give for 5 to 10 years, Right? But we reassess, and we'll give a break. And if they need it, again, we can have it. There's nothing. So the vitamin D. So yeah, I looked at, I was looking at, I think there was advice. I'm not sure. I was told that you need to keep a high vitamin D levels, but I can't find any. I didn't find any evidence about that. I think more than 50 would be perfectly fine. So we don't have to keep too much, because very high vitamin D levels itself can cause problems, because that can cause calcification. Tissue calcifications are sometimes can cause hypercalciuria if they are if they're producing more calcium. And people with particularly hypoparathyroidism people, we don't need that much, isn't it? So yeah, we limit. And again, calcium, on the same note, if they are taking their calcium to the diet, that's fine. So we don't have to advise the calcium, because the calcium with evidence of cardiac disease and heart disease and things. So I think that's more of evidence is coming up. So if they're taking calcium diet, it's fine. You don't have to give calcium.
So we know that a lot of the cardiomyopathy is reversible when you've got severe myeloma. How much of the endocrinopathy is potentially reversible as you bring down the iron overload?
That's a good question. So to be honest, don't know. But I don't think there are a lot of prospective studies. But so I think we need to. I think probably need to, as far as I know, there is because by the time they come to us, the hypopituitarism and hypoparathyroidism. So there were anecdotal reports, but I haven't seen anything, any study or anything to say that completely gone reversed. I think it's important to know that in a few years in the next, we need to collect the data and see that. Yeah.
Do you have any questions from the online feed? Well, thank you very much.
Okay, thank you very much. Thanks for the opportunity. Thank you.